So we're pivoting off intraoperative hypotension because I think we're a bit bored of discussing this now. We recognize the fact that it's very, very common and possibly a lot more common than we thought it would be. Drawn to our attention initially in recent years probably by Dan Sessler and the team at the Cleveland Clinic, but subsequent following up publications reiterating the message that it occurs much more commonly than we had thought. In this example here, published from the MPOG group, the Multi-Center Perioperative Outcomes group, looking at the mean duration of hypotension, defined as a map of less than 65 for 1 minute or more, the 11 centers overall demonstrated an incidence of 88% of hypotension with a mean duration of 28.2 minutes. So I would put that in the category of, ooh, that's quite a lot. And the range by center goes from over 20% to close to 30%. Now, this is just 1 minute of hypotension. We'll come back in a moment to some data where the hypotension is longer than that. Now, we're told it's harmful, and I think this is intuitive, because not only is it associated with subsequent mortality, it's also associated with two of the potential silent killers. That's acute kidney injury and myocardial injury after surgery, which are both silent events. So although they're indicated by an elevation in a blood level of a protein, the patient can't feel it, and we as providers can't see it. And we're told that below 65 for longer periods, there's quite a risk. Below 55, there's a very significant risk. I'll get my colleagues to comment in a second. This has also become very familiar to us. It's almost ready to be sort of presented as an image without the writing on it, because it's a systematic review looking at a whole group of papers, looking at mortality across the top, acute kidney injury, myocardial injury, stroke, delirium, and overall organ injury. As you go down the left-hand side, it's got mean arterial pressure going from 80 down to 40, and then the duration going through 1 minute, 5 minutes, 10 minutes, and 20 minutes. And the executive summary, dominated by the left-hand side of the slide, is harm starts to appear at 65. And by the time you get to 65, it's potentially very significant harm. Of note, there isn't a strong signal with stroke, which we'll come back to discuss. Mike, could you talk us through this paper? Because that literature, to many of us, was very much dominated by excellent work from the Cleveland Clinic, but we've been asking the question, does it apply to a much broader grouping? So what's gone on here, Mike?
Yeah, so Andy Shaw's group looked at retrospectively again at data, real life science. The key thing, this was multi-center in all ages, and it shows a similar sort of heat map really. On the y-axis here, you've got intraoperative hypotension with thresholds of 75, 65, and 55. And along the x-axis, you've got odds ratio. And so what they looked at was the cardiac and cerebrovascular events. And you can see that it gives a similar signal. So you've got increase in 30-day mortality in a dose-dependent fashion to hypotension, and AMI, and AKI, CRT. There's a signal of harm for the brain with delirium, but interestingly not AIS. But I think that's probably because acute strokes are normally thromboembolic. So if you think of when we deal with stroke and the stroke alerts, it's nearly always something that you can actually do something about with a mechanical thrombectomy or thrombolysis. But the other really interesting thing for me is I've always felt that good perfusion means good gut function, and good function means you get less PONV and less downstream sepsis. And I think this is shown quite nicely in this paper in a large population.
Because if we flip that over and look at the evidence, we'll touch on it a little bit in a moment, that addresses intraoperative hemodynamic instability by addressing all of the variables, it treats all of the things that have gone out to the right, if you see what I mean. So you get less morbidity, myocardial injury, acute kidney injury, et cetera, et cetera, et cetera. And I kind of get the stroke thing because it doesn't happen very often. And if you do see post-operative neural problems, it tends to be delirium. Is that fair? I mean, we don't see ischemic strokes that often, do we? No. Not dismissing them, but they're very rare events.
No, the only ones I've seen in the last few years have been thrombotic.
Thrombotic strokes. Okay. So anyway, the other thing to note here is, as I remember, this is hundreds of US centers and tens of thousands of patients. So I think this is a sort of a tipping point for us to say this is very generalizable. Now, yesterday morning, we saw a presentation, a main session podium presentation from a group of us discussing this work between two major US anesthesia groups. Desiree, you were part of the team that did this work.
Yes.
Tell us a little bit more about it, please.
Yeah, so a project that we've been working on, it's two large national anesthesia companies coming together in the vein of quality to look at the incidence of IOH in a real world setting. Now, I know it's a little bit tenuous and when you first think about it, two large national anesthesia groups, North Star Anesthesia and USAP, US Anesthesia Partners, came together. Normally we would be competitors in this space, but wanted to take a look and see if we could, see the incidence of IOH in our practical practice type settings. So a lot of the research that's been done in the past are large academic centers, and so we wanted to take it down into our community-based facilities and see, are we actually seeing the same rates of hypotension? Is it maybe less? Is it maybe more? And so we did that. We looked at patients through the lens and defined IOH through the lens of the E-Pre-Op 31 MIPS measure. So this basically is defining MAP as less than, or IOH as a MAP less than 65 for a cumulative total of 15 minutes or greater. And it was for patients age 18 years or older, and it was in non-emergent, non-cardiac, general, neuraxial, or regional anesthesia care. And we only looked at ASA status 2, 3, and 4. We excluded monitored anesthesia care, obstetric cases, transplants, cataracts, and endos. So got rid of a lot of those.
So to repackage that, you were looking at what we call bulk standard community-based
Running the mill, yeah.
Because before that, the feeling was you're reporting this in academic centers in patients who are getting a high level of monitoring. This is ASA 234, and it's dominated by younger patients having shorter procedures, et cetera, et cetera, et cetera. So give us a headline, and then we'll just discuss what we made of it. Okay.
Yeah, absolutely. So all cases, we had a patient population size of about 100, almost 130,000 cases. And for all of those cases, we had a mean less than 65 for 15 minutes or more in 29% of those cases, with a total time of IOH of about 12 minutes.
But why is that 12 if it has to be 15 minutes?
Right.
So the standard is a cumulative quarter of an hour.
Yes.
With a MAP below 65, and that happened in almost a third of the patients. Why is the 12.4?
So that total time is for all patients in that patient population. So we broke it down and looked at the time of IOH just for the numerator, which was about 36,000 patients who experienced IOH, and that duration of IOH was about 36 minutes for patients.
Were you surprised at that result?
What was really interesting is that high level, I was surprised. I kind of knew a lot of the cases that we were submitting into this. We do large complex spine, so I kind of actually thought, that first study that we looked at, maybe to see a little bit higher rate of IOH, but across the board, it was pretty high, and it was a longer duration of IOH. Most of the cases that fell into this category were ASA2s. They were about 2 hours, and so that was a lot surprising to us.
So this is not, because yesterday there was a lot of discussion about the fact you seem to be celebrating how bad you were, between the two groups, but this is consistent with the other literature from academic centers. Is that right, Mike? This is a consistent message?
Yeah, I only saw this data today, but it is amazing if you think that I used to think it's hypotension was in ASA 3-4 patients, but we're showing that there's actually more in treatment centers in the ASA 2 patients. So we're having a profound physiological effect on patients when we anesthetize them.
And this paper's been submitted for publication.
It has.
And you also looked at ambulatory surgery centres, which is a very hot discussion topic, and surely ASCs are okay because you go in, you have
not necessarily young, but healthy patients. What we found was an incidence of about 31% of IOH in that patient population. So those were really surprising numbers to us. We did not expect that at all.
Okay, and please do, if you have more questions about that, please do write them down and we'll come back to that towards the end.
Yeah.
So the takeaways from that?
Yeah, so it's fairly common, in line with a lot of the literature that was out there already in academic institutions, confirmed what Shaw looked at in that particular study. What the biggest opportunity for us, we feel, in the quality space, and again, why USAP and North Star wanted to go into this, is to look for ways to improve quality. And what we found is that that the rate of IOH was really independent of the patient risk factors. What varied the most was the clinician, and it's us delivering the anesthesia that created that variation in that IOH.
And the range was very dramatic.
It was
from what
very
I saw.
dramatic.
So there's like almost none with some providers. It's
Right.
a bell-shaped curve,
Right.
and almost guaranteed with some other providers. So that seems as though you could do something about that, Mike.
Yeah, I mean, the good thing we know is wherever there's variance in practice, it means that there's room for improvement,
Yeah,
provided we know how to fix the problem.
absolutely.
And just to give a little teaser for what's coming up next, you're going to tell us how you made that change.
did it.
Correct,
Is that-
yes.
Yeah, there we go. That's good. So one of the concerns, and we've had this in discussion since that data's been reviewed, is we can't assume that the people who are at the, let's call it what we're assuming is the good end of the spectrum, who have very little hypotension, are producing the best results. Because we've all seen this trend that's happened of restriction, fluid restriction from enhanced recovery being misinterpreted, and using vasopressors because we've been told to avoid hypotension. Have you seen this in your practice, Desiree?
Yeah, absolutely. I mean, since the whole message has come out, everyone has bags of vasopressor hanging in anticipation of IOH and to avoid IOH.
Mike?
Yeah, well, obviously, being one of the proponents of ERAS, the thing that's come out of ERAS is everyone talks about restrictive fluids, but of course, it's the restriction of post-operative IV fluid. It's not restriction of fluid in the operating room. And so to me, I'm very worried that the message that's getting out there is restrict the fluids. And I've noticed a lot of surgeons sort of are saying back to me over the blood-brain barrier, saying, oh, you don't give this patient too much fluids. And I'm saying, well, I'm using flow monitoring, so I'm going to give them exactly the right amount of fluid.
So we saw this in the United Kingdom when we introduced enhanced recovery, and back in 2010, 2012, we had to make corrective measures because we were seeing this rise in just the use of vasopressors as opposed to using monitoring to guide the treatment of preload, afterload, and contractility. And we're now seeing publications from the US saying that the same thing is being seen. So the multi-center perioperative outcomes group just published in the British Journal of Anesthesia 20, 30,000 patients over 5 years, and exactly the same trend is there. Not saying it's not important to treat hypotension, but it's how we treat it is what I believe. And
Absolutely.
here's two examples, two studies, and Mike will mention another one in a second, looking at acute kidney injury rates, and these are two large prospective randomized controlled trials. One is the RELIEF trial, so 3,000 patients led out of Australia, an international multi-center trial, that when they compared restrictive zero balance fluid in enhanced recovery patients to moderately liberal, in other words, they went back to giving the litre around the time of induction of anesthesia and then a bit more during the case, so they ended up slightly positive at the end. Acute kidney injury rates went down from 8.5 to 5%. Fedora, which is a multi-center Spanish trial, took that one stage further and used a fill flow pressure approach to optimize stroke volume, and then asked the question, is the MAP above 65? And if it was, carry on. If it was below 65, is the cardiac index greater or less than 2.5? And if the index was okay and the MAP was down, they treated afterload. And if the index was down, they treated contractility. And Mike, you had another example for us.
Yes, I did, yeah. I think for people in the audience to know a little bit about me with my English accent, I actually came across the US and had my first job down in Virginia, and I was actually National League with Monty in enhanced recovery in the UK. And in Guildford, where I was, we're a big cancer centre, and we use this principle, fill flow pressure. I think we're the only centre in the world, this is going back to 2003, where we use flow monitoring for every single major surgical case. And we had a very low AKI rate, very low SSI and post-operative sepsis rate. So I brought that across to our institute in Virginia. And I think the next slide shows some data that we were mapping before we introduced this. We did a very large study to try and map what our problem was. So this is literally hot off the press. It's in the Journal of Clinical Anesthesia this month, and it's mortality and costs associated with acute kidney injury following a major elective non-cardiac surgery. I want to give credit here to Brenton French, who's my surgical QI fellow, Pranav Shah, and all the crew there, because they had to go and look at the Social Security data set. We had cost modelling. But the headline is, you can see the graph on the right there, is that in this large population set, again 6,600, non-cardiac, it's a large urban academic teaching centre. We did the mortality before the COVID pandemic, so that didn't interfere with it, and we used K-Digo criteria. So on the right there, you've got the top line is the survival curve at 365 days for someone with no AKI. Then you've got at the bottom stage 3 AKI, which you sort of expect because they've normally had a very bad perioperative period. And then in that pink is the stage 2. But the thing that hasn't really been mapped before is the stage 1 AKI, which is novel. And you can see that the stage 1 AKI it gives you as profound an effect at 1 year as almost stage 2 does. And yet most of us just consider stage 1 AKI as a small bump and a bit of inconvenience. So on the next slide,
I'm just going to pause for 1 second, sure, Mike, just to remind ourselves, because this has been one of the great debates. Stage 1 acute kidney injury using the criteria that are chosen is what we used to call a creatinine bump.
Yeah.
So your baseline creatinine was 100, now it's 150. Yeah. That's stage 1. It's not, I'm seeing the nephrologist, I'm on a hemofilter. No, it's a silent creatinine bump.
Yes, stage 1 is an increase from 1.5 to 1.9 times your baseline, or a 0.3 milligram per deciliter rise. Stage 2 is 2 to 3 times, stage 3 is 3 or more. So this is really quite a minor change.
And that is survival probability. So you're more likely to be dead at 1 year, putting it crudely, if you had a creatinine bump. Now, we have to be careful with associations and causation, but...
Correct, yes. This is showing that all stages of AKI have a downstream mortality risk.
And that is, in the latest consensus documents, that's broadly accepted now, that there's no such thing as a benign creatinine bump. You might get away with it, but on a population basis, you're potentially harmed for a long time. Next slide, Mike.
Yeah, I think this was just to show, we went into detail of costs as well, because I had to show our exec board, if we are going to introduce flow monitoring, are we going to save any money? So the first thing is you can see that there is additional inpatient day associated with stage 1 AKI of 1.9 days and 2.6 for stage 2. Stage 3 is obviously patients are very sick. And then in patient mortality, there's an increased risk, but not a huge signal, to be honest. The signal amplifies as you go out to 1 year. So you can see that for rather than percentages, we did odds ratios, because then it indexes according to your health. And you can see the odds ratio of dying at 1 year is 1.9 for stage 1 and 2.4 for stage 2. So that really surprised us. And what's more, the cost impact surprised us. It was $4,391 for stage 1 AKI, $6,739 for stage 2. So when we got this data, it was very powerful, basically saying, well, why would we not use these monitors, which will save bed days, which releases bed capacity, reduces harm to the patients, and improves their long-term life expectancy. So it enabled us to get flow monitoring in a lot more easily.
So the length of stay goes up, understandably more with the stage 3. There's increased mortality out to a year, and there's a big financial difference. So correct. I think we can all understand, as we've already said, if we can reduce complications by using an alternative approach, it's not only good for the patient, it can make financial sense as well. I think you've demonstrated, you've intervened and demonstrated in some centres that you can deliver that dream.
Yeah, so I was trying to reproduce the model we had back in Guildford, and we did this used fill flow pressure with 2-point optimization after induction of anesthesia using flow monitoring devices, and we halved our AKI. In one particular population, the colorectal, we had a very high AKI rate of about 15.5%, and we took that down to about 7%. And that's another paper which is in process, hopefully to be published soon.
Desiree?
Well, Mike, this is the first time I've seen these or earlier today, and one of the points that you made was, it's very controversial whether or not it's us anesthesia affecting the rates of AKI versus, it happening downstream. And you were able to kind of filter that out a little bit.
Yeah, so I think one of the uniquenesses of our paper, if you go into it, is we actually mapped AKI through KDIGO criteria, not for the 48 hours post-op, which is what's normally done for quality indicators. We looked 7 days out. And what was fascinating is we actually had a bimodal distribution. So there's another little bump at the end of day 4, day 5. So there's something else that's happening to patients in hospital which is causing an AKI. There's some sort of pathophysiological event, or we're not quite getting our fill flow pressure right during the days post-op to days.
There's been some other recent publications about that. I think we'd all intuitively say that if there's a creatinine bump day 1, day 2, and it maps back to our fluid restriction and our use of vasoactive agents, it's got our fingerprints on it. But if they were fine at day 1, day 2, and then it goes up at day 5, that's not me. Is that fair? Is that the message?
Well, we don't know, but
Okay.
I think when we look at quality indicators for anaesthesia, it's something we do need to take into account for, because if not, we might be taking responsibility for something which we don't actually own.